Next, we have Dr. Arvind Morya.
Yeah, please play.
Greetings. I am presenting a case of Sturge-Weber syndrome
Volume.
who was one-eyed with complicated open-angle glaucoma. This patient was in his late 30s with bisymptomatic encephalotrigeminal angiomatosis. His one eye was PL negative after multiple failed trabeculectomy and drainage device placement. Other eye was having tunnel vision, 6 by 18 and on 5 anti-glaucoma medications. So, the routine trabeculectomy is associated with multitude of complications including choroidal detachment and hypertony. Placement of valve is bulky and costly. Hence, we plan to implant a Make in India Omniflow drainage device in his only functional eye. This is how this 50 mm length with 0.3 into 0.7 mm drainage device looks. Retrobulbar space behind the equator is almost free from myofibroblasts. Therefore, it is virtually free from fibrosis even without mitomycin C and can drain up to 500 microliter per minute. After putting a L-shaped cut in the conjunctiva and after little blunt dissection, a wire vectis was inserted to reach retrobulbar space to make a track for this device. Up to 40 mm of wire vectors can be inserted with ease to create a tract. Then about half of the tube was placed with the walled distal end into the retrobulbar space that goes quite smoothly. After this, the tube was primed using 27 gauge hydrocannula to check the patency. Gentle and minimum wet cautery was performed. This was followed by partial thickness markings on the sclera using a MVR plate at 5 to 7 mm away from the limbus. Then a scleral tunnel was made with 23 gauge MVR blade. This tunnel was properly lubricated with 2% HPMC. The proximal end of Omniflow was now inserted and passed through the scleral tunnel after few attempts. Then the proximal end was sharpened by cutting it obliquely using a scissor. Now, a second scleral tunnel was made which was radial to the limbus up to 2 to 2.5 mm from behind the limbus, which was then gently entered into the anterior chamber, bisecting the angle of anterior chamber and the iris. Intracameral pilocarpine was pushed into the AC. Now, the beveled end of the Omniflow tube was inserted into the anterior chamber via the second scleral tunnel. Utmost care was taken so that only the beveled 1.5 to 2 mm end goes inside. Then the excess band of the tube was pulled back and slowly pushed back into the retrobulbar space. The Omniflow device remains firmly in the two tunnels. Finally, the conjunctiva was well opposed using few interrupted 8-0 Vicryl suture.
Or even
During the post-op period, IOP came down to 12 mm of Hg with only brimonidine eye drop in continuation with best corrected visual acuity of 6 by 12 and was maintained till last follow-up of 8 months. So, Omniflow is a short shunt and the best glaucoma drainage device to drain aqueous from AC to the retrobulbar space by preventing hypertony and keep IOP between 10 and teens 24/7 with least use of anti-glaucoma medications. Omniflow will revolutionize the management of all types of primary or secondary and intractable open-angle glaucoma, neovascular rubeotic glaucoma, silicone oil-induced angle recession, posterior ambryotoxin, and glaucoma in Sturge-Weber syndrome in a most cost-effective manner without trabeculectomy and use of mitomycin C. Thank you.
So, there are no complications which are associated with trabeculectomy with this device, like the choroidal effusion, the detachment, and the CME.
How many cases have you used it in?
113 cases.
And have you compared it with?
Yes, we are comparing it with the trab with mitomycin C. The study is going on.
This very ingenious device, it just seems to be a simple catheter. I mean, if it works, it's great. So, is it any different from a small What's the inside bore? Internal
It's a
bore?
Teflon valve fitted that we need to put it into the retrobulbar space.
So no, what's the internal bore of this?
It's 0.7 into 0.1, and the Teflon valve is 175 to 250 microns.
It's a valve.
Yes,
device?
it's a valve fitted at the retrobulbar end.
The valve is there to avoid
Yes.
excess flow.
It works on the principle of this Bernoulli's. So minimum back pressure of 10 to 15 millimeter of Hg will always be maintained in the anterior chamber.
So why shouldn't it maintain all trabeclectomies? I mean, replace all trabeclectomies. This could become the
Yeah,
procedure
and,
choice.
in last 4 years now we have more than 1,000 implant all over India.
How does it differ from aging?
It's totally, the principle is totally different. It's very small, whereas that is very bulky. Right, and the principle is different. So what we have, after a lot of research, it took us 6 years. It's team of Kakadia sir, Shah sir, me and Dr. Satish D. Sheth. So we were able to titrate the capillary diameter that will be sufficient to maintain the back pressure in the anterior chamber. So finally we come out, and this 175 and 250 micron, it works very well. So 15 millimeter of Hg will always be maintained. That is the beauty. So there is no hypotony, no, in not a single case.
And you did mention that the fibroblasts are not much in that area.
Yeah, the
Meaning
retinal
no
surgeons are
by-
exploiting that space long, since eternity. They are exploiting this place because it's absolutely almost free of myofibroblast.
So no need for a mitomycin
Yeah,
C, I think
it's
that-
not required. Not required. We can save the limbal stem cells also. Mitomycin C not required. Even pediatric ophthalmos cases, we have implanted 27 cases working very well as a primary treatment.
Are you using it also in place of routine trabeclectomy?
Yeah, now I
on
have
the
stopped
PVIs?
doing trabeculectomy. Yeah, I have stopped doing trabeculectomy. Only in the angle closer, I'm doing trabeculectomy.
What's the cost of this device?
8,000 plus GST, available with Excel Optics Private Limited, Chennai.
Why 8,000?
Research took a lot of time and energy and money, so
You have patented it?
yeah.
So I thought of making one of my own.
You are most welcome in our other innovations.
Okay. Thank you so much,
Thank you.
Dr. Arvind. Do you want it back, Dr. Arvind?
Yes, 3 year, it was only 4.3, it's maintained, it's not much, no.
Do you want it back, Dr. Arvind?
No, you can keep it.
Dr. Ramamurthy wants.
Yes, I will share you more samples. Anyone want?
he wants to
Please
give
let
for
me know.
But if you're
Chitra.
putting it
Yeah.
in the retrobulbar space, then there must be, I mean, there are no side effects or nothing like that.
Yeah, no side effect, no. So though we need to measure the how much tube we need to implant. So the formula is axial length plus 5 millimeter. Under microscope you will be able to see.
No, but then this appears to be too
So
simplistic.
the formula is axial length plus 5 millimeter. Rest of the part we need to cut it.
Okay. Thank you so much, Dr. Arvind.